You know that feeling, that sudden shark tummy ache that just stops you in your tracks?
Hmm.
Well, imagine that, but in a baby, hitting them seemingly out of nowhere. And it's caused by something, well, really serious going on inside.
Yeah, it's quite alarming.
Today, we're doing a deep dive into intussusception. It's a pediatric medical emergency, and it's definitely something you need to have on your radar.
It really is. And what's striking is how a baby can seem perfectly fine 1 minute and then suddenly become critically unwell.
So what is it exactly?
Intussusception. Well, it's basically when one part of the bowel slides or telescopes
Oh,
into the
cool.
part right next to it.
Yeah.
A bit like, one of those collapsible travel mugs folding down.
Okay, I can picture that.
Except here, instead of saving space, it causes a blockage.
Hmm.
And worse, it can actually cut off the blood supply to that trapped part of the intestine.
Right, or like pulling one sock right inside another one.
Exactly like that. A really good analogy. That's
Yeah.
essentially what's happening.
So our aim today is to really nail down what it is, why it happens, who's most likely to get it, what cascade of events it sets off in the body, how doctors tell it apart from other things, the typical age group, those key signs to watch for, how it's diagnosed, treated, the outlook.
And the potential complications if it's not caught quickly.
Precisely. Think of this as your sort of streamlined guide for revision. Really get this topic down.
Okay. So let's start with the formal definition, just to anchor us. Intussusception is when one segment of the intestine invaginates, that's the technical term, into an adjacent segment.
Invaginates, like tucks into.
Exactly, tucks into itself. And the critical results of this, as we've said, are obstruction, so nothing can pass through properly.
Right.
And compromised blood flow to that trapped piece of bowel.
And does it tend to happen in a particular spot in kids?
Yes, it does. While theoretically it could happen anywhere along the bowel, the absolute most common site in children is the ileocecal valve.
Ah, where the small intestine meets the large one.
Precisely that junction. Now, what actually starts this process? Often, it can be something seemingly minor, like a slightly enlarged lymph node in the gut wall. That acts as a lead point and gets sort of dragged into the next section.
It's just a little nudge.
Yeah. Or sometimes it might be small growths, like polyps or maybe other benign masses.
Okay, so something starts it off, and the bowel just folds in. And you mentioned the blood supply. That sounds like the really urgent part.
It is. It's a true medical emergency. If it isn't treated promptly, that lack of blood flow to the tract bowel leads to tissue death. That's bowel necrosis.
Ooh.
And eventually it can lead to perforation, where a hole actually develops in the bowel wall.
Right, okay. That really underlines why spotting it fast is so critical. Let's dig into the why a bit more. What are the usual culprits, the etiology?
Good question. We can sort of group the causes. There are the common scenarios we see in young children, and then there are situations, especially in older kids or adults, where we suspect an underlying structural problem, a pathological lead point.
Okay, unpack that for us. What about the younger kids first?
Right. In most young children, probably the majority, we actually don't find a specific smoking gun cause. We call it idiopathic.
Meaning the cause is a bit of a mystery.
Exactly, a bit of a puzzle. But we do see strong links with common childhood viral infections.
Yep.
Things like rotavirus, those really nasty tummy bugs.
Yeah, unfortunately.
Adenovirus, too, and also HHV6, human herpes virus 6.
Okay.
Then there are what we call non-pathological lead points. Think of Peyer's patches. These are little clusters of immune tissue in the lining of the small intestine.
Like tiny immune system outposts in the gut.
Great way to put it. If these get a bit swollen, maybe after a mild virus, they can sometimes act as that trigger point that gets pulled into the bowel. Less commonly, you might see things like amoebomata, which are masses from amoebic infections, or bacterial infections like Shigella or Yersinia acting as triggers.
So, often tied to those common bugs kids pick up.
Very often. Now, if we see intussusception in older children or even adults, our suspicion for a pathological lead point goes up, a specific structural issue.
Like what?
Could be something like a Meckel's diverticulum, that's a small pouch in the small intestine wall that some people are just born with. Or polyps, maybe associated with conditions like Ports-Jeger syndrome, lymphoma, or other tumors can do it too. Even things like an inflamed appendix, cystic fibrosis, or nephrotic syndrome can, in some cases, create that lead point.
Wow. Okay, so a much wider range of possibilities in older patients, often pointing to something physically abnormal there. Makes sense. Now, who's most likely to get this? What are the main risk factors?
Age is definitely a big one. It's most common in infants and young children. The peak incidence, the real hotspot, is between 5 and 9 months old.
That's specific. Why that?
Well, it often lines up with when babies start solids and also coincides with the time they get more viral infections. Both things can potentially trigger that lymphoid tissue in the gut we talked about.
Interesting. Any other key factors?
Gender plays a role, too. It's quite a bit more common in boys. The ratio is roughly 3 boys for every 1 girl affected.
3 to 1. That's quite a difference. Any idea why?
The exact reason isn't crystal clear. There are some theories, maybe differences in how the intestines move, or perhaps the size or reactivity of that lymphoid tissue in baby boys. We're not entirely sure.
Okay. What else?
Another really important one is having had it before. Unfortunately, if a child has had intussusception, their risk of it happening again is higher.
Oh, okay. Recurrence is a risk.
Yes. And we also circle back to those viral infections, particularly rotavirus. That link is pretty well established. And interestingly, there has been some mention in studies about a potential association with recent vaccinations, though that's still an area being looked into.
Right. So mainly young infants, more often boys, especially if they've had it before or had certain recent infections.
Yeah.
Now let's get into the mechanics. What's actually happening inside the body, the pathophysiology?
Okay, so at its core, like we said, it's that telescoping action. One bit of intestine slides into the next, causing a physical blockage. Sometimes we break it down, maybe 75% of cases are non-pathological, where we don't find that specific lead point. The rest have an identifiable cause. But the real problem starts when the mesentery gets squeezed.
The mesentery.
Yeah.
Think of it like the sheet or sling that holds the intestines in place. It's also crucially important because it carries all the blood vessels, nerves, and lymphatic vessels to the intestines.
Ah, the supply line.
Exactly. So when the bowel telescopes, this mesentery gets compressed. That not only causes the physical blockage, but also makes the bowel above the blockage swell up distension.
And that squeezing must have knock-on effects.
Absolutely. It messes up peristalsis. You know, that wave-like motion that pushes food along?
Yeah.
That gets disrupted. And that's what leads to that classic colicky abdominal pain that comes in really intense waves, and also the vomiting.
But crucially, that pressure also blocks the lymphatic drainage and, even more importantly, the venous blood flow out of that trapped section of bowel.
So the blood can get in, maybe, but can't get out easily.
Sort of, but the pressure builds up fast and affects inflow, too. The net result is ischemia, basically. Not enough blood supply getting to the tissue. And if that goes on too long, well, that's when you get the tissue damage, the necrosis we talked about.
Right. Ischemia leads to necrosis.
Precisely. And while, yes, the ileocecal region is the classic spot, it's worth remembering this can technically happen elsewhere in the intestines, too.
Got it. A real domino effect, starting with the telescoping and quickly compromising blood flow. Okay, so if a child comes in with these kinds of symptoms, what else might be going through a doctor's mind? What are the main differential diagnoses?
This is super important for revision, definitely, because lots of things can look like intussusception, especially in young kids with tummy pain and vomiting.
Like what?
Well, you've got to consider things like abdominal hernias, definitely appendicitis, though it can present a bit differently in infants. Even simple colic needs to be thought about, although the pattern of pain is usually quite different.
Right. Colic is so common.
It is. Gastroenteritis, those common stomach bugs, are always on the list. For boys, testicular torsion is a crucial one to rule out quickly. That's a twisting of the testicle, cutting off blood flow, a surgical emergency itself, but it can sometimes cause abdominal symptoms.
Okay. Hadn't thought of that presenting abdominally.
It can happen. Other things include volvulus, where the bowel twists on itself, not telescoping. Blunt abdominal trauma could be relevant. Maybe cyclical vomiting syndrome, gastric volvulus twisting of the stomach this time, and other types of intestinal hernias.
Phew. Okay. That's quite a list. Really shows why careful assessment is needed. Now, just how common is this? Give us a sense of the epidemiology.
Sure. The estimated incidence is somewhere between, say, 20 and 60 cases for every 100,000 children per year.
Okay, so not super rare, but not every day either.
Exactly. And as we said, that peak age is really quite specific, usually hitting between 3 and 9 months, though the broader range it mostly affects is infants from about 6 to 18 months old.
Right.
And just to hammer it home for memory, much more common in boys, that 3 to 1 male to female ratio is a key fact.
Got it. 3.1 boys, peak 3-9 months, mainly 6-18 months. Okay. So let's get practical. What would parents or caregivers actually see? What are the classic signs and symptoms? The clinical presentation.
The symptoms can be pretty dramatic. A really key feature is severe abdominal pain, often starting very suddenly. Parents might describe the child pulling their legs up towards their chest like they're trying to ease the pain.
That drawing up of the legs.
Yes, a key indicator. Vomiting is another very common early sign. As the blockage progresses, the vomit can start to look bile-stained, greenish.
Right.
Then there's the later sign, but it's highly specific if you see it. That's the bloody stool with what's described as a current jelly appearance. It's a mix of blood and mucus.
Ah, yes, the current jelly stool. That's the classic one you hear about.
It is. Definitely a red flag, though it often appears later in the course. Maybe a memory tip? Think red jelly for a red flag.
Good one. Red jelly, red flag.
Exactly. Now, on examination, a doctor might actually be able to feel a mass in the abdomen, often described as sausage-shaped, typically in the right upper quadrant.
You can feel it.
Sometimes, yes. You might also see signs of dehydration, dry mouth, sunken eyes, reduced wet nappies because of the vomiting and not wanting to drink. Pallor, so unusual paleness can be there. And in severe cases, you might see signs of shock. The child could also be very irritable, maybe sweaty.
Okay, so sudden pain, legs drawn up, vomiting, maybe that jelly stool later, and potentially a palpable mass. Anything else about the presentation?
Yes, the pain pattern is important. It often comes in waves or paroxysms, really intense colicky pain, maybe every 10 to 20 minutes. During these episodes, the baby might scream, drop their knees, look pale. But what can be quite striking, and sometimes confusing for parents, is that between these attacks, the infant might seem relatively well, almost back to normal, maybe a bit tired but comfortable.
That okay in-between period sounds really key.
It really is. We also mentioned the vomiting becoming bile-stained fairly quickly that points strongly towards a bowel obstruction. In some more serious cases, you can even get neurological symptoms like lethargy, unusual floppiness, hypertonia, or even altered consciousness.
Wow, neurological signs too.
Less common, but serious when they occur. There's also a specific physical finding called Dance's sign, DANCE''S. That's where the right lower quadrant of the abdomen feels unusually empty on palpation because a bowel that's normally there has telescoped upwards.
Ah, because it's moved. Dance's sign.
Got it. And late symptoms to be aware of besides the red currant jelly stool might include a fever or pyrexia.
Okay. That cyclical pain with the well period seems crucial. Any other quick memory aids for the features?
Well, you can think of the classic triad. Sudden onset, colicky abdominal pain, vomiting, and the currant jelly stools. But, like we stressed, remember that stool is often a late sign. Don't rule it out just because you haven't seen it, especially early on.
Good point. And the drawing up of the legs.
Definitely a key behavior parents often notice and report.
Okay, so suspicion is high based on these signs. What happens next? How do we confirm the diagnosis? Investigations.
Imaging is absolutely central here. Ultrasound is usually the first choice. It's very good, highly sensitive and specific for intussusception, and importantly, it doesn't use radiation.
Safe and effective, what does it show?
It shows a really characteristic picture. You might hear it called a target sign or a donut sign. Imagine looking at the bowel end-on. You see rings, like a target. Or sometimes viewed from the side, it might be called a pseudokidney or a sandwich sign. Basically, you're seeing the layers of bowel within bowel. Think of a bullseye on the ultrasound screen. That target is the key visual.
Bullseye. Got it. Those descriptions really help visualize it.
They do. Now, an abdominal x-ray can sometimes be useful too, especially if you're worried about a general bowel obstruction picture, or more seriously, a perforation error where it shouldn't be.
Okay.
And then there's the contrast or gas enema. This is really interesting because it can be both diagnostic and therapeutic.
How does that work?
Well, you gently introduce either a contrast liquid, like barium, or just air, into the large intestine via the rectum. On the X-ray images, this can clearly show the blockage where the intussusception is. But the pressure of the liquid or air can often gently push the telescoped bowel back into its proper position.
So it confirms it and potentially fixes it at the same time?
Exactly. It's quite neat when it works. But there is a small risk involved, mainly the risk of causing a perforation if the bowel wall is already weakened, so it has to be done carefully.
Understood. Are there specific signs on the enema image?
Yes, if contrast like barium is used, you might see the crescent sign, where the contrast caps over the top of the intussuscepted part. Or a filling defect, where the telescoped bowel physically blocks the flow of contrast, sometimes looking like a claw or a coil spring. Nowadays, air enemas or water-soluble contrast are very commonly used too.
Okay, so enema is key for diagnosis and potential treatment. What about blood tests?
Blood tests aren't really for diagnosing the intussusception itself, they're more supportive. A full blood count, or FDC, might show a raised white cell count, particularly neutrophils, suggesting inflammation or infection. And urea and electrolytes, UNEs, are really important to check the child's hydration status, see if they need fluids urgently, especially with all the vomiting.
Makes sense. CT or MRI?
Generally not the first line in children. They get used much more often if intussusception is suspected in an adult, where the causes are often different. In kids, ultrasound is really the go-to.
Ultrasound first, maybe enema. Got it. So once it's diagnosed, what's the management plan? How do we treat it?
Right. The initial goal is usually non-operative reduction. That means trying to fix it using that therapeutic air or contrast enema we just talked about. That's the first line approach.
Try the enema first.
Yes. Surgery is generally reserved for cases where the enema doesn't work, or if there are signs of complications like a perforation, or if the child is too unwell for an enema attempt.
Okay, but before trying the enema?
Absolutely crucial first step is stabilizing the child. That means getting intravenous fluids in, correcting any dehydration or electrolyte imbalances, and usually giving prophylactic antibiotics just in case there's bowel compromise or risk of infection spreading.
Stabilize, then reduce. Makes sense. How often does the enema work?
Actually, the majority of cases, a good percentage are successfully treated just with the enema reduction, using air, saline, or contrast.
That's good news.
It is. Now, if the non-surgical attempts fail, or if there are red flags like peritonitis inflammation inside the abdomen or signs of perforation, or maybe a very long history suggesting the bowel might be damaged, or if we strongly suspect a pathological lead point, then surgery is needed.
And what does surgery involve?
It can often be done laparoscopically, keyhole surgery. The surgeon tries to gently squeeze or milk the telescoped bowel back into place. If that's not possible, or if there's damaged bowel that needs removing, then an open operation, a laparotomy, might be required.
Okay, so keyhole if possible, open if necessary.
Exactly, and that really highlights why early diagnosis is so important. The sooner it's caught, the higher the chance the enema will work, and the less likely surgery will be needed.
Right. What if the first enema doesn't work, but the child seems stable?
Sometimes, yes, a repeat enema attempt might be considered, depending on the clinical situation and local protocols.
And hospital admission is standard.
Almost always, yes. Treatment and observation are needed. Very occasionally, in highly selected, stable cases after successful reduction, outpatient management might be discussed, but admission is the norm.
Okay, sounds like a clear pathway. Stabilize, attempt enema reduction, surgery if needed. What's the general outlook for these kids? The prognosis?
Generally, it's very positive, provided it's diagnosed and treated in good time.
That's good to hear.
Yeah. As we said, most cases are sorted out non-surgically. The main thing families need to be aware of is the chance of recurrence.
Ah, yes, you mentioned that risk. How common is recurrence?
Estimates vary, but it's somewhere in the range of 5 to maybe 15% after a successful reduction. So it's definitely something to keep in mind if symptoms reappear.
Okay, 5–15% risk of it happening again, but overall survival.
With treatment, the mortality rate is thankfully very low, around 1% or even less in developed countries with good access to care.
That's very reassuring. Quick intervention makes a huge difference. But what if things go wrong? If diagnosis is delayed or missed, what are the complications we worry about?
This is where things can get really serious, unfortunately. A missed or delayed diagnosis is the biggest worry.
Because of the blood supply issue.
Exactly. That leads directly to intestine ischemia, the lack of blood flow. That can then progress to sepsis or septicemia, serious infections spreading through the bloodstream.
Okay.
If the ischemia goes on too long, you get necrosis, parts of the intestine actually die, and dead bowel tissue can perforate, creating a hole.
Which leads to?
Peritonitis. Infection and inflammation spreading throughout the abdominal cavity, which is life-threatening.
Wow. So a cascade of very serious problems.
Yes. And in much rarer situations, you might see a sort of chronic low-grade intussusception that isn't causing an acute emergency but smolders on. And that can actually lead to failure to thrive in an infant.
Failure to thrive.
Oh.
Okay, that's another potential long-term issue. These complications really hammer home the need for speed.
Absolutely. Time is bowel, essentially.
Yeah. Right. So to wrap up our deep dive on intussusception, what are the absolute must-know take-home messages for revision?
Okay, key points. Intussusception is a serious but very treatable emergency. It mainly affects young children, think 6 to 18 months, peak 3 to 9 months, and it's more common in boys.
Right.
Early recognition of those classic symptoms is vital. the sudden, severe, colicky pain, the vomiting that might turn bile-stained, drawing up the legs, and maybe those late current jelly stools.
Don't wait for the jelly.
Exactly. Diagnosis leans heavily on ultrasound, think target sign. Treatment starts with stabilization and usually an attempt at non-operative reduction with an enema. Surgery is for failed reduction or complications. And crucially, prompt diagnosis and treatment lead to a very good prognosis, though recurrence is possible.
That's a fantastic summary. Super clear, hits all the key points. It really does show why we need to be so vigilant, especially in that young age group. Thanks so much for walking us through all that.
My pleasure. It's an important one to know well.
Absolutely. And for all of you listening and revising, if you're looking for more top-notch resources to really nail your exams, definitely check out pastthemsra.com and also freemsra.com. They are packed with high-yield information to help you smash it.